First and foremost, of course, thank you so much for inviting me to talk about my research. As you know, researchers love to talk about their own work, so this is always a good thing to happen to anybody. Secondly, unfortunately, I'm quite ill and heavily medicated today, and sorry if this affects the seminar. It will definitely have affected the quality of this presentation, so sorry in advance for that. That out of the way, let's begin. So a bit of the background of suicide in Belgium. Belgium has a very high suicide rate within Europe. I looked online and it was quite recently, 2022, it was 18.4 per 100,000 people age standardized rate in Belgium. You can see it on the map here that it's a very big outlier regionally as well. And I just very briefly checked before, and according to the WHO, it's about twice the rate in the UK. So that gives you a bit of a feeling like, okay, this is a big problem in Belgium comparatively to other countries. There's also a bit of background on the project that this evaluation was a part of. In March 2021, 3 leading professors in Belgium in public health sciences were contracted by the Flemish government to do cost-effectiveness evaluations of 10 suicide prevention policies to be delivered quite soon in October that same year. Of course, if you bring together 3 of the finest minds on public health sciences in a country, then that's going to create some amazing synergies and brilliant insights. So they decided to wait 5 months before hiring anybody on this project until August 2021, where they panic hired a recently graduated Dutch health economist with a spotty academic record, which was great for me, and now here I am. In October, 3 months later, after a crash diet of coffee and Ritalin, we did in fact deliver those 10 health economic models to the Flemish government. And more than 3 years later, the only paper so far to come out of that horror show has finally been accepted into a journal, which is why I'm here today. So that's a bit of the background on the project and the road to, or the background where this one paper came from. Within that space of 10 projects we evaluated, every policy proposal came with a prospectus sheet of about 2 pages where the people who wanted to implement the policy and of course also receive government funds to do the policy in practice presented their evidence for the costs and the expected impact of the policy on suicide. So they were expected to present their data sources. That way we health economists would get a head start. For most of these 10 projects, the expected impact source looked something like this, which is generally not directly applicable to health economic evaluations by economists. Fortunately, there was one of these policies that did actually have hard evidence, namely a randomized controlled trial instead of the hopes and dreams of poppies worldwide. And that was the ASSIP proposal, which I got the happy long straw to work out, essentially. In a nutshell, the intervention is to reduce suicide reattempt rates. So it's a targeted intervention aimed at people who have attempted suicide already and essentially give them a direct treatment. This follows from the premise that people who have attempted a suicide have been observed epidemiologically of having a greatly increased rate of reattempting suicide within those first 2 years following an attempt. Afterwards, it's a bit spotty. If it's still elevated, likely yes, but statistically might not always show up clearly in the data. The intervention itself is to give those people who have attempted suicide free, short, and very targeted therapy sessions. I'm not a clinical psychologist, obviously, so I can't really say how the therapy itself works. But as a helicopter view, it's aimed to both reduce the feelings that give rise to attempts, but also to give patients a direction to find better therapy in the event of a future crisis. So they get basically a pamphlet with where they can go for help when a crisis hits. After those 4 sessions, it's not on the slides here, but they are also receiving semi-regular follow-up for 2 years in terms of just small check-ins like, hey, are you still okay? And then after those 2 years, ASSIP really stops fully. The delivery mechanism is to train therapists in the delivery of ASSIP, and they sort of are mobile across the entire country. So hospitals who have a patient following a suicide attempt can just contact one of these trained therapists, and the therapist goes to the hospital and delivers care inside the hospital. But overall, they are mobile across multiple hospitals at the same time. The trial reported a decrease of 80% in cumulative reattempt rates. We found that very optimistic, and after some internal survival statistics and some arcane mathematical sorcery tricks, we arrived at a much more likely 45% reduction that we would expect in real life instead. I'll talk a bit more later on about that, but that's just a quick heads up already. The model we developed to analyze this was a very run-of-the-mill Markov model. It's one of the first models I made in my career as a health economist, so it was, in a sense, not too complex, which was good. People start on the left where they have an acute state of 1 week where we just assume they are in intensive care recovering. Afterwards, they get the offer to join into the ASSIP treatment. Roughly, from the trial, we know that roughly 60% refused to participate in ASSIP. This seemed a bit high and maybe related to the fact that people didn't like trials as well, but we just stuck with this quite high rejection rate in this model. Roughly 40% say, okay, let's do the ASSIP treatment, and they get the 3 ASSIP sessions. There is an optional 4th session, which was taken about 25% of the time, which can just help hammer down the therapy a little bit more for those who feel they need it. If you don't get the ASSIP treatment, so treatment as usual, or if you drop out, you go to the regular risk population, which is just the people with a regular risk for a suicide reattempt. Treatment as usual is a bit of a misnomer in this model because there, at least at the time when we modeled this, is no real structural treatment for people recovering from a suicide attempt. Besides, of course, the medical direct life-saving treatments, there's no real structural plan. After a week, they are released, they get a slap on the shoulder, go get them, tiger, and that's it, essentially. Of course, there is a bit of a mix that people actually do on their own, find their way to psychiatrists and psychologists, and that was included to some extent into the model. But just to say that the ASSIP sessions already themselves are a big improvement in the sense that there is a structural policy in place instead of everybody does something on their own. If you do complete ASSIP completely, then you enter the reduced risk population. And because of a weird government quirk in their KPIs, they needed to track the 1st and 2nd suicide reattempts following a policy. separately. So we stuck that as a first suicide attempt, and then you can go to a second suicide attempt from there. Just a government request, so that was into the model. And of course, following suicide reattempts, you can actually die by suicide. The health economics side, personally, I don't find costs and utilities all that interesting in terms of the parameter space. I'm much more interested in transition parameters, but of course, they are hugely important in getting the health economic results of a model. Generally speaking, we included cost for a suicide attempt and a completed suicide, both direct medical costs and a societal extra cost if for the societal perspective. We had treatment as usual, was a bit of a mix, again, of some costs that we could reasonably gather were commonly sought after by people on their own. And then there was the assisted ASSIP startup cost, so a one-time cost of 220,000 K one time, and then a cost per patient, which we developed based on Belgium cost data and the RCT data about the ASSIP trials. We also included some utility scores. That was all just sourced from the literature directly. Of course, for both costs and especially the utilities, the parameter uncertainty for mental health evaluations is incredibly high. Usually there is no direct data available, and if there is, then it's usually easy to find 5 versions with complete opposite relations or impacts. Of course, you do a sensitivity analysis as a health economist, but because there was so much just fundamental uncertainty about every parameter into the model, we took a very deliberate conservative approach. What I mean by that is that costs or parameters were intentionally slightly over or underestimated when this was a bias against the intervention. So the clearest example of this would be completed suicides. We found a range of costs that could be associated with completed suicide, but since a higher cost per completed suicide would be beneficial to the intervention, we chose the lower estimate that we found to sort of have a slight inbuilt negative bias whenever we needed to make our own judgment calls, essentially. I will talk a little bit more about that later as well. The results were quite good for our base case analysis. It was very clear that ASSIP was a dominant intervention after 20 years. So if you let the intervention run for 20 years, it's actually saving costs as well as saving lives or improving quality of health, no matter how you prefer to look at it. And you can see that here in the graph as well, that you have series 4, which I forgot to rename, which was the treatment as usual group, essentially have an equilibrium cumulative percentage of reattempting suicide of 20% after 2 years. And this was roughly 8% for the attempted suicide short intervention program group. But how realistic is this exactly? Because we have trial data for the first 2 years, which is well better than you normally get for mental health interventions in the first place. So that's a very good thing that we had trial data, but it only covered 2 years. Essentially, what happens after those 2 years when the intervention stops completely is completely unknown and not tracked by any data so far, at least not when we made this model. And the assumption, of course, is that after 2 years in the base case, that they have the same reattempt rate. So at this point, after 2 years, the slope of the blue group is the same as the slope of the red group. But what if these slopes are not the same? That's the big question that we added in our paper when we looked into this. Which is the meaning of that question is, what if the ASSIP intervention is not avoiding suicides in those who take it, but actually just postponing it? Could be. Again, we are not clinicians and we don't only have evidence for 2 years. So we fundamentally have no clear idea if it's an avoided suicide or a postponed suicide. Likely, it's a mix of both. So that's where the rebound scenario analysis kicks in. Here we essentially take, after those 2 years, a perspective what if a small proportion of those who initially avoided a suicide reattempt a suicide after 2 years. And we took time for that to occur of 2 years again. So after 4 years, this time we reach a steady state in both scenarios again. So it could be a little, it could be as extreme as in 4 years, the cumulative rate is actually completely the same, and 100% of the people who initially avoided a suicide rebound, and it's actually just 100% postponed suicides. Of course, even in that super worst case scenario where everybody reattempts suicide at a much higher rate than the initial 2 years, there's still a health benefit in the model, of course, because there's the difference in the area under the curve for the red line and the blue line. So the benefit is still there, it's just temporary. Could still be cost effective technically. So that's what we analyzed, and it was actually great news because the effects of the intervention can magically reverse by 82.7%, almost completely reverse after those 2 years and go back to the same cumulative rate almost, and the intervention would still be cost effective. So that's a very robust result. Again, this is not necessarily a likely expectation to happen. A lot of interventions, a lot of the clinical perspectives on how ASSIP works would suggest that most of these people who avoided a suicide in those 2 years have avoided it, not postponed it. But even in those worst case scenarios where we were completely wrong about that assumption, we have an incredible range before it's actually no longer cost effective. So that's already our first policy conclusion, just directed at the attempted suicide short intervention program. It's a very robust, cost-effective intervention, which was found by the original randomized control trial, who did a small health economic arm to their study as well. I think there have been a couple of other studies in the meantime as well who looked at the cost effectiveness. I think they found similar results. But of course, policy-wise, you should never expect miracles. It only targets the reattempts, so people who have already attempted a suicide at least once. 60% of those people still do not want to participate, and there can be still real practical hurdles that were not included in the model. One of which could be the intervention capacity. Like I said, it trains a handful of psychologists to deliver this therapy across the country. But if there is suddenly a peak suicide wave and they can't manage essentially in that week to visit all the people who want to follow the ASSIP treatment, then that could be a lack of capacity, essentially. That was, of course, not included in the model. Belgium also has a crippling fear of having any common national language whatsoever. So while any country can experience language barriers, they are especially applicable in the Belgium context. So people who attempt suicides might not actually have access to trained psychologists who speak their language. Again, that's also a problem of the intervention capacity, where most psychologists only speak 1 or 2 languages at most, of course. Finally, we will always need post-implementation evaluations because it's not very informative to have just one pre-implementation expectation-based evaluation. We always need a post-implementation evaluation to have the best available evidence. If we zoom out generally, and then I'm going to implicitly also consider the other 10 or the other 9 interventions we have modeled, we found that they don't need to be amazingly effective in general to be cost effective. Of course, that also should consider the costs of these interventions. ASSIP was by no means an outlier in low cost, in terms of low cost. So a low cost intervention would of course be quicker to be cost effective, but it was not a positive outlier there. Generally, even if they have very minor effects, it can be cost effective already. And we saw that in the tipping point analysis in this case, that in fact of the reported 80% in the trial, actually we only needed 7.7% decrease in a very targeted group to be cost effective. If we looked at our policies that were general, i.e. not targeted to a specific subgroup, but more aimed at the general population, that required percentage was far, far less. Of course, we didn't have a lot of good data for that, so we never actually got to publish anything about those other 9 projects, but this is something that we saw as we look at them as a whole, essentially. Of course, when you include the societal impact, the benefits are only going to become greater. That is because there is in no way a better societal impact if you let people commit suicide. So that's only going to push the cost effectiveness dynamics into the positive direction, obviously. Closing, I want to present some lessons we learned with those 10 evaluations. Of course, these are more general and somewhat personal lessons, not gospel. They're personal perspectives in the sense that we did not do any follow-up literature reviews on how to best do health economic modeling in mental health. Just a sort of short assessment of what we felt we learned about this general process. First was to keep the models relatively simple. I love making large complex models. It's in fact what I like to do most during my postdoc. But with mental health, the data to populate and make a large complex model work almost never exists in any form that you can use uncritically. You have to adjust it, you have to combine disparate data sources and hope for the fact that they are actually applicable to each other. It's generally a nightmare to get good data. And even if you have a randomized controlled trial, if you're lucky, then still that's one trial. Usually there's a bit of a positive bias in what they will report. So even the relatively hard side of a randomized controlled trial is not a guaranteed ticket to having data that you can blindly follow. And you can see that in all our models, our state space was essentially every time a treatment, a post-treatment, a suicide attempt, and dead as treatment states or state space states. And in that sense, I would recommend against modeling depression, mild, medium, and high in a mental health model, which we did in a couple other models. But it was generally messier because you cannot find good hard parameters to model depression to a suicide attempt directly, usually at least. Second, involve expert stakeholders, preferably ones that are not involved directly with the intervention. So we did work together with some psychiatrists, psychologists, and mental health experts at a policy level when we did this project. But crucially, none of them were, for example, involved or planned to be involved with the ASSIP implementation in Belgium. This, of course, helps immensely with parameter uncertainty. When you find a large scale of possible parameters, you can just quickly check, like, hey, what is a reasonable assumption here? For example, that 80% reduction was immediately and anonymously flagged by all the experts. I said, like, that 80% is never going to happen in real life. Of course, you can't really ask them, like, okay, what is a reasonable percentage? Because that's very subjective from the expert's point of view, of course. But at least you know, okay, this is something that's very defensible to adjust downwards, since experts have problems believing that this is a valid parameter. So it's immensely beneficial to include them early on and just check whatever you are not sure about with the expert stakeholders. Be very conservative in your free choice space, essentially. This came up during this presentation already a couple of times, where I mentioned that we took a very conservative, almost negatively biased approach against parameters. And this has a very simple reason. If you take a very, if you have or can be accused of having a positive bias, for example, you underestimate the treatment costs of the attempted suicide short intervention program. If you, I think it was 1,000 euros in this model per patient. If I would have said 200 euros, obviously a very low underestimation, then nobody would believe any result coming out of this model at any point. We took the higher end of the cost spectrum there, and we still got a positive result. So great, we have a very defensible conclusion now. And if we had gotten a negative result, then that means, okay, no, we cannot conclude this is cost effective, don't do it, but maybe we need better data. It doesn't close the door on the intervention entirely. It just says from the available data now, we cannot be sure. Which is great, because it shouldn't be a closed door for policies when there's simply a lack of data. If there's conclusive data and that shows it's a no, then the no really stands. It's good to have sort of like that open, that slight crack in the door where people can still say, like, okay, maybe we need to work on it some more. Finally and lastly, what we also saw was that a tipping point analysis is hugely appreciated by both the academic journals who want to publish it, but also generally for the policymakers as well. We discovered it quite late in our process, but it proved immensely beneficial to everybody involved to see, like, okay, how much leeway is there in the expected effects? How much can it reduce before I actually change my conclusion about the policy? Somewhat arbitrarily, we picked a rebound effect. So we took the first 2 years of effects as correct, and then we modeled an unexpected rebound after that 2 years. Of course, it would have been equally valid to model the spectrum of immediate policy effects as well. So you don't have to wait after that 2 years after your trial data. You can just start at year 0 essentially and do a similar tipping point analysis. But do include one, especially in the context of mental health, because they are very hard to get published, which is also something that we see if we look at how much studies on health economic evaluations of mental health actually find their way into literature. And that leads me to some recommendations, which are definitely more on the subjective side, but still, when I look at the academic literature from health economists on mental health interventions, we see that there's a clear lack. There are very few of them, especially when we compare them to things like stroke or cancer. But and this is something I checked right an hour before the presentation, but mental health is definitely not some niche or cheap pathology for the society. Obviously, we all know that roughly 20% of people will have a lifetime moment of mental health problems that require some form of intervention. And the burden of mental health on a society, which includes the treatment costs, but also the social security impact and the loss of productivity, suggests that it's roughly 4% of GDP, which is quite a lot. Actually, that's almost twice the impact of cardiovascular disease or cancer, which of course also are somewhat negatively impacted by the fact that they usually happen later in life versus mental health issues. So of course, that means that it's generally less impactful from a simple cost perspective when you include the societal side. But that's beside the point. It is, in fact, a very big part of the disease burden that a country faces. So there's a good argument to make to say, okay, we need to divert some resources from the sexy diseases like stroke or cancer and move a bit to the harder ones of the mental health space. Second, we need a bigger boat, which goes directly against my advice earlier of using simple models. But I think there is a very good case to be made to work on a larger unified mental health evaluation model. There exist several of these for cancer and cardiovascular disease, as well as for environmental health policies that try to model multiple interventions at the same time on the same population in a very structural way, which also includes the interaction effects between multiple policies. Why do I think this is worthwhile? Because when you look at mental health interventions, it's the norm to have concurrent treatments. Many people have to get multiple treatments, but also have therapy and medication and maybe something completely different on the side as well, except instead of just one standardized golden treatment guideline. Usually they have many treatments at the same time, and these treatments interact with each other. So you can't really say antidepressants by themselves are effective, yes or no, because usually they are administered in addition to cognitive behavioral therapy or something like that, and that has an interaction effect. So it doesn't make a lot of sense to have models that always assume a vacuum. Furthermore, those simple models also can't include any psychosocial risk factors that we know are very important, especially for mental health and suicide risks. Of course, age and gender can be included in most models, and they are, but socioeconomic status, which can have a very big impact on who can get into therapy and who cannot. Life events like losing a job, losing a relationship can also have immense impacts. That's all typically not included in these models. That sort of is similar to as if all cancer models, that there were no cancer models in the world that included smoking as a risk factor. That would be very strange if you suddenly realize that why are these very real and identifiable risks never included into models? Well, we don't have the data for it, so it's hard to fit them into models that try to include them. But if we combine resources as researchers across multiple countries, then I think it would make sense to make an attempt at a larger unified model that includes at least some psychosocial risk factors and the effect of concurrent treatments. This can also show, of course, the need for a layered approach of interventions. So you can actually say, like, okay, we have an intervention that is directed at reattempt rates, the ASSIP policy, but we also have interventions aimed at general prevention at the entire population as a whole, and these also interact with each other. But of course, this is not an easy task, but I wanted to throw it out there as something that I personally think would be worthwhile in the mental health space of health economic modeling. That is all I have prepared for you. I hope it was at least vaguely intelligible. Feel free to reach out, of course, in the future, but for now, I'm happy to take any questions that there are. Sorry.
Great, thanks, Max. Really like your second choice of contacting you. Chant your name backwards in the mirror 3 times. I'll try that later, right after this presentation, see if that works. Have we got any question from the audience?
Richard.
Oh, Richard, please go ahead.
Yeah, thanks very much, Max. That was really interesting. I guess it's not necessarily a question, but a sort of thought in relation to the sort of more unified model that you were talking about. So I'm doing an evaluation on an intervention to prevent self-harm. And through our sort of reviews and the way we're planning to do our economic model, it's going to be very much a sort of self-harm focused model, and we're not really going to incorporate suicide. And I think that I've also had sort of similar thoughts to you, that it would be better if we could particularly incorporate self-harm and suicide into sort of a more single unified model, and that might be a sort of useful place to start because they're often thought about in the same context, but there are sort of distinct patient groups, groups that sort of only self-harm, and then other groups that sort of self-harm and then potentially progress to suicide attempts. So yeah, I don't know whether you thought that was a sort of had any thoughts on that area and why they're not often incorporated in the same models, and if it's an interesting way to go.
Yeah, but thanks for that question. I think definitely it's a worthwhile endeavor to see if we can expand models. This is something, my dissertation was about cancer screening, but tried to tackle a similar dynamic in modeling, which is how big a model should be and can be. And my perspective is that a model should be as big as possible, but it is inherently limited by, 1, the available data that you have, and 2, the available resources that you have, which is somewhat similar, but also involves the amount of time that you have. So, of course, if you have 3 months for 10 models, you're not going to make any big models. But fundamentally, in mental health, we are limited by the incredibly large gap in usable parameter data. We have a lot of good evidence that socioeconomic factors and the interrelationship between different pathologies as well. So if I make it specific to your question of self-harm and suicide, we know that there is an overlap and a relation between those two. We have probably loads of estimates on how strong that relationship is, but if you make a targeted study of that relationship, you will find that it becomes widely different depending on how you build your model and what intermediate states there are, and then it can quickly fall apart. And that's the big challenge I find with the researchers I've spoken to who did mental health studies, is that getting this into a cohesive structure that includes more than one intervention in a vacuum is mainly about that restriction in evidence and data that you can pool in a short time. So yeah, if there's the option to bundle forces across countries and across pathologies, then I think that would be worthwhile. I hope that answered your question, comment.
Thank you.
Yes, please, Matt.
Thank you. Thanks, Max. That was great. If that's you under the weather, then you must be very, very good at presenting when you're feeling top notch. I'm not a health economist. I'm a policymaker, but I've got a vague interest. And I'm wondering what was the impact of the study? Did you find that the policymakers responded positively to your analysis and therefore increased investment in this particular service or wider services? And if not, why not?
That's a good question. In Belgium, the governments are required by law to get these evaluations for any policy they want to roll out on a national level, which frequently means that we are contracted by the government, but the government isn't necessarily interested in our findings. Usually they have decided their policy already, and they really, really, really hope, fingers crossed, that our analysis will just tell them, okay, do what you want. In this case, however, compared to some of the other projects we have done, they did really like the overall idea that, yes, these evaluations, especially if they're about multiple projects at the same time, can allow you as a government to direct your funds to the ones that are most impactful from a cost effectiveness perspective as well. That became very relevant because after 2022 in Belgium, they had to face suddenly severe budget cuts, and not all these